Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is of a patient who attended with an ear infection in this there right ear, and you can see all this discharge, what we call otalgia. So otalgia is just the fancy medical name given for ear pus or ear discharge, and it's really wet, and they do have a chronic history of suffering from ear infections. They are hearing aid wearer as well, and if you are prone to having ear infections, sometimes a hearing aid can exacerbate the infections, and that's because this patient wears a hearing aid with a mold piece, an ear mold, and although it's got a ventilation hole running through, it's quite a small ventilation hole, and that is in part because of their hearing loss. They've got quite a severe hearing loss, and if you have too big a ventilation hole, not only does a lot of the sound that's being amplified in the ear escape back out of the ear through that ventilation hole, but it can also lead to acoustic feedback, so whistling of the hearing aid. And that's audible to not only the patient sometimes, but also those around them. And we just have to be really gentle, and especially where we are now, because we don't know how thick this layer of discharge is, and if you're going too quickly with the suction probe and you go through the layer of discharge, you'll make direct contact with the eardrum. And I can just about starting to see the eardrum now. You can see that blue tinge. So all this yellowy, pale yellow debris, that's the infection, and then that is coating the eardrum completely. This patient could not hear at all when they arrived. And again, I'm just using the suction probe here, just hovering over some of this discharge. And you'll see me a bit later in this part of the procedure go back in with a fine end suction probe and just spend a bit of time getting this discharge off the eardrum. Now, already at this stage, this patient can hear significantly better. They will, of course, need antibiotic, either spray or drops or oral tablets. This infection, it's a bit of a misnomer sometimes. So patients sometimes believe or under the impression that if they've got an ear infection and we suction clear out that discharge from the ear, that the infection then goes. Fortunately, it doesn't, because when we suction, we're just removing the debris. All the bacteria is still there. Now, if you regularly clean the ear, so if this patient comes like every other day, because if this is left untouched, what will probably most likely will happen is all this discharge will come back. So if you regularly clean the ear, then yes, maybe you might stay on top of it. We're keeping the ear dry, and we're giving it a good chance for the ear to recover. But this patient will need antibiotic, and in fact they've already got it, so they've seen the doctor already, and they were booked in with myself first. So it's always advisable, if possible, that if you have got a blocked ear like this, to have the discharge blocked, because that they can't hear at all anyway. And when they have their medication, I think they were prescribed ear spray. It's spray that's prescribed by the GP. Antibiotic, it contains also dexamethasone, which is a steroid which reduces inflammation. The antibiotic is neomycin, which is an aminoglycoside. And it also contains acetic acid. Quite often when patients have an ear infection, the natural pH of the ear should be around 5.4, so it's slightly acidic. And if you've got an ear infection, the pH level changes to an alkaline pH, and acetic acid, so vinegar, helps just to reacidify the ear. And the acidity is good because it helps to fight off bacterial and also fungal infection. So you can see here, we're just using a fine end suction tip right up against the eardrum, just hovering over. Don't want to perforate this patient's eardrum, because it would just make matters worse. And yes, there's going to be a bit of debris left. We could be there for hours and hours and hours, and it'll be uncomfortable for the patient. Already I can see far more of this eardrum. I'm just going to go around the edge. And fortunately, the patient is really still for me, because it's not always possible to perform these types of procedures on some patients, and it just depends how steady they are themselves. Because if the patient does move and you're that close to the eardrum, there's no real getaway. The suction probe is going to make contact with the eardrum if they move suddenly. So I'm just going here in the attic. Now this part of the eardrum is very sensitive, and I've just come away, and I think I will go back. I'm going to get a different angle. So I can go up towards it. So as you can see, the majority of the eardrum is now visible. And you may have noticed this patient's, the entrance of the ear is completely collapsed. And I'm using the endoscope to stretch open the ear. So I think this is when I just got a different angle. I've just hovered over it in that attic region. I just wanted to make sure there's no retraction pocket there. But that part of the eardrum, is, the other name given to it is pars flaccida. And the main body of the eardrum is called the pars tensa. So that top part of the eardrum's a lot more flaccid. It's a lot more, hence the name, flaccida. It's a lot thinner. It's not as rigid and strong as the rest of the eardrum. So you've got to be careful in that top region. Now you can see the majority of the eardrum there already. You can see the hammer bone in the centre. There is some, on the where I am now, there's some scar tissue here on the patient's eardrum. It's slightly opaque. This type of discharge is quite difficult to kind of suction at times. It's quite gloopy and glutinous. We can see that beautiful view of the eardrum now. I'm really pleased with that, especially considering how their ear was when they first arrived. So that's the patient's right ear. We've recommended them not to wear their hearing aid. Now, on their hearing aid, their earpiece, the mould, they've got a ventilation tube that was blocked, and that's not going to help. When someone's prone with otitis externa, so this outer ear infection, you want that ventilation hole to be open so it breathes and it allows air to enter and exit the ear to aerate it, helps circulation of the air as well. So this is the patient's left ear, same patient. So they have also got otitis externa here, but it wasn't as, well, it is quite bad actually, but it was no otter ear, there's no discharge, this is just dead skin. You can see how we're peeling it away. And the eardrum is visible in the background. Again, they've got a very narrow ear, and this suction probe, this is this full-size Zollner suction probe, just about kind of fits in the ear. And the entrance is, so if we don't stretch the entrance of the ear open, we wouldn't be able to insert the suction probe in. So we're just stretching that open. I'm using the endoscope as a doorstop, and not only is it a doorstop to keep the entrance open, it's also allowing me to visualise. See that stunning view, so you can just right up against the eardrum here, just using the suction probe. So the eardrum's visible already. You can see this patient's, if you compare it to their right ear, it's slightly opaque as well. There's a bit of scar tissue on the eardrum. So both eardrums look very similar now. Just right at the bottom and really close to the eardrum. So we're going to be really careful. Now, because this patient is prone to having ear infections, I'm trying to just get as much skin out as possible, obviously, of course, without making it uncomfortable for the patient. And that's because the more skin I get, this skin's not unfortunately going to migrate by itself. It's just going to die and shed, and it's going to become damp and then infected. And the patient is aware that they need to attend regularly to have their ears cleaned, to keep on top of it. So I'm just trying to remove as much as I can, really. But it is difficult just because of the narrowness of the ear. And when you've got a narrow ear like this, to shut the entrance, it's hard, number one, to get the instrument in the first instance, but then manipulating the instrument in the ear so you can pull the skin here, there, right and left, it's quite tricky. I think in a moment I'm going to bend the suction probe so I've got better angle. This is the anterior canal wall. Skin sometimes can be strongly adhered. It's not, it's different for everyone, but sometimes skin, you just have to really, really work at it and peel it away bit by bit, and on other occasions it just comes off without fight. So this one's a bit tougher. Just doing it nice and slowly. Patience is a virtue when it comes to clinical ear care. It's one of the things that I stress to our delegates. In fact, one of our recent delegates contacted me the other day, and they had a case and just wanted some advice. And they were just saying how frustrating it was. And they're doing everything right from what they explained to me. They're doing everything right, and but sometimes it's not always possible to remove earwax in one visit. I know ENT as well. I've got colleagues who are ENT consultants, and sometimes they also have to bring people back. So it's not always possible. And I just explained to the delegates not to worry. They've done the right thing, and just to get the patient to use some drops and further soften it for them. Now, I don't generally ask my patients to use drops. If I need to use the drops myself, as you know, I use it during the procedure. And I'm trying out a new olive oil spray at the moment, which is really exciting. They're made by a pharmaceutical company not far from me actually, and we're just giving some advice and tips and working kind of with them at the moment. So it's quite exciting when you've got new products and you can try them. We're nearly done. I think I'm gonna kind of stop the procedure as soon as I think after this little bit, and there's a bit at the top I think I go back for. So that skin, I think I gave up on that skin on the left, on the front part of the ear canal. I was just too peeled away the majority of it, but that last flap of skin just didn't want to come out and didn't want to cause the patient any injury. So I'm just going to the top part of the ear canal, so I got a bit out there. And I believe now I'm just going to mop up near the entrance. Just a lovely, stunning view of the eardrum. So yeah, there's a few flakes around here and there, but sometimes you just got to quit whilst you're ahead, because it's putting up a good fight. And like I said, we got the majority of the dead skin out, and sometimes, you know, especially when I first started, I was probably guilty of trying to do too much, and I've learned over time less is more. Especially when you can give it a go, but if it's putting up too much of a fight, you got to accept, like, you know, you've done enough. Well, I hope you enjoyed that video, guys. Take care and speak to you soon.